are joining. So be patient with us for a moment or two, and we'll start, okay? I will say that if anybody has any questions they'd like to ask, just please put them in the chat. We'll be monitoring that throughout the next 30 minutes. We have a nice mix of employers. We have some broker consultants that are on as well. We encourage you to make your employer clients aware of this really important opportunity that can really help shape how they purchase healthcare going forward. It is known that healthcare premiums that employers and their plan members pay, approximately 50% of that premium is due to hospital services, both inpatient and outpatient. So this is by far the biggest spend that any employer has in their health plan. So with that, we're going to start. Next slide, Sam. I have the pleasure of introducing Brian Briscombe, Dr. Briscombe, who's a senior quantitative analyst with RAND Corporation. They'll further introduce themselves in a moment. And Dr. Rachel Reed, who's a practicing physician, but also a public policy researcher with RAND. So Brian and Rachel, if you want to say anything else about yourselves, we can then get started.
Ryan, why don't you go ahead first?
Oh, I was going to say ladies first. Okay, I'll just briefly say that I've been working on these RAND studies for a while, and we have been mostly focused on healthcare costs throughout all the projects I'm involved in at RAND. Over to Rachel.
Yeah, so I'm a physician policy researcher at RAND, where my work focuses on measuring healthcare cost, quality, and value, and how the way that we structure and pay for healthcare influences the quality and outcomes of care that patients receive. And I'm also a practicing primary care internist here in our Boston at Brigham and Women's Hospital. The next slide would be great, I think. Perfect. And so we're going to introduce you guys today to the RAND Hospital Price Transparency Study with an eye towards round 6 that we're currently in active recruitment for. We're partnering with employers across the country to provide information about healthcare prices to drive market change. Perfect. So I probably don't have to tell this group that, given that you are all here with an eye towards employer-sponsored health plans. However, pointing out the size of the employer-sponsored market and the weight that it can carry. $1.4 trillion in total U.S. healthcare costs in 2022, the last year covered by round 5 of the RAND Hospital Price Transparency Study. 160 million people covered by employer-sponsored health insurance, and $486 billion in commercially insured hospital spending. So a large part of that market is indeed in the commercial market. Next slide, please. Perfect. So the RAND Hospital Price Transparency Study itself. This is the largest claims-based analysis of commercial hospital prices in the United States. We're recruiting for round 6, and that means that we've successfully completed 5 rounds prior to this. Round 5, the one that reflected claims through 2022, analyzed $80 billion or more in hospital spending across the country. And our coverage included more than 4,000 hospitals in 49 states. We've historically excluded Maryland because they have a unique hospital pricing system. And this work has gained trust over that decade of experience from employers, from policymakers, and from the media nationwide. Next slide, please. And this slide here shows the history of the project. It began in round one with employers in Indiana, focused entirely on facility claims. And over the ensuing rounds, 1, 2, 3, 4, 5, has expanded in the scope to 49 states, expanded to include APCDs, all payer claims databases, in addition to employer claims, giving us a broader breadth in the claims that we cover. It's expanded to include both inpatient and outpatient professional claims where they can be paired to an inpatient or outpatient claim, as well as including some information about standardized prices, service lines, comparisons to ambulatory surgical centers over the years. So the study has gotten both more comprehensive and more in-depth over time, and we're continuing to build on that for round 6. Next slide, please.
I wanted to add one comment on that. You saw expanding APCDs. We are working right now with the now fully funded Texas APCD, so we hope to be able to include those claims, which include about 60% of the claims filed in the state of Texas. So we're excited about that possibility. We're working through the details now.
Thanks so much, Chris. Yeah. And this can show you some of the high-level insights that we gain from the RAND study. And this slide right here is a nationwide look. And that 254% number is the average percent of Medicare prices among hospitals nationally in 2022. A thing to flag is that number is kind of the headline number that catches most people's attention. What the RAND study really focuses on is both that number, but we don't know which number is exactly the right number. That is ultimately for employers to be aware of and decide in their negotiations. But the important thing around that number is there is a wide spread of variation, both within and between states. And you can see that spread between states if you look at that graph at right. You can see Texas sort of in the middle among the states that are there, but states average from 100%, 170% of Medicare in Arkansas to above 335% in Florida and West Virginia. So there is a widespread and a wide range across states. And that wide range exists within states too. And the analyses that we've shown, our team has done in the past, have shown that that is driven principally by hospital market power. The mean ratio that we observe by state has held relatively steady across the last several rounds that we've studied, from 2018 to 2020 to 2022. Highlighting that this percent Medicare, or what we call the relative percentage price, is persistent and not a one-time finding. And with that, I'll pass the baton to Chris for the next slide.
Thank you. And even though that number has held relatively steady, given the price increases that employers have been experiencing, I am going to just take a wild guess and predict that number is going to be a little bit higher this next round. I wanted to talk about Texas for a moment. The other coalition that I lead is Texas Employers for Affordable Healthcare. We have a dashboard on our website that has data for close to 300 hospitals in Texas. And there's a lot of good metrics on there. But just as a way of demonstrating the variation, you can see there that a minimum, I'm guessing that's a critical access hospital, paying 97% of Medicare to 484% at another hospital in Texas, with a median of about 280%. I can say that because I work in the Houston market primarily, that the average price employers pay in the Houston market is 316% of Medicare. The chart to the right shows the commercial break even. The total facility fee for hospitals, not taking into account physician prices. And let me say that the providers, it's not the physicians, it's not the nurses, it's not the staff that is driving up the cost. It is the charges related to facility fees. There's a lot that goes in that. We don't have time to discuss it right now, but suffice to say that the break even is 110% versus 270. That 110% is the amount that the employers in Texas would need to pay for the hospitals in aggregate to cover all their operating costs for commercial, Medicare, Medicare Advantage, uninsured, charity care, and S-CHIP. And these are not numbers that we made up. These are numbers that come from the hospitals of CMS cost reports that are provided. These numbers were calculated by the National Academy for State Health Policy, with whom we partner in our efforts here. So I just wanted to provide a little bit of perspective in Texas here. Next slide. Oh, another comment here. What does this mean? By the way, as Rachel said, we're not saying what that profit margin should be for a hospital or what that price should be. We're just noticing that there's almost a 3x variation in that break even and the amount paid by employers, inpatient and outpatient in Texas. So how can this be used? All healthcare is local. It can be used collectively by employers in a market to collectively voice their concern and perhaps work with hospitals to understand where opportunities for better pricing might be. I'll give you a couple examples. In New York, a large employer, 32BJ, used the RAND data to kick New York Presbyterian out of their network. You would think there would be a lot of concerns by employees, but because of this, each of their employees was given a $5,000 raise, and they haven't had no premium increase in 5 years, as an example. The same organization is now doing direct contracting with Mount Sinai at a percentage of Medicare well under 200%. You would think the other hospitals would be really concerned about this. Their response, they now want to do direct contracting. So this can be done. A large employer in Texas, National, Aramark, is doing direct contracting in Dallas right now. They offer their PPO and an incentivized direct contracting option. Mark Cuban, of course, is doing his own work with Cost Plus Wellness and his direct contracting arrangements there. By the way, our organization is having a forum August 26th, 27th at Rice University on alternative purchasing strategies. Mark Cuban is going to be our featured speaker at that. So anyway, there's a lot of different ways this data can be used, but first we have to get your data in there so you can use it. So I'll step back, and Rachel and Brian, you can take it home.
Thank you, Chris. So yeah, I'll take care of the remaining slides, and we'll focus on what data we need to do this study and how to join and participate. So basically, as the previous slides indicated, we're looking at medical claims only, and we're looking at both the facility and the professional claims. This time in round 6, we're going to focus on 2023 through 2025. And we always do a 3-year time period like that. You don't have to worry too much about exactly what data fields are required. The TPAs and the data warehouses, or whoever is handling your data, they'll take care of all that. As you can imagine, we're focused on the allowed amounts, and we have to identify which hospital each claim belongs to. So usually the TPA or carrier will facilitate. We already have data use agreements in place with Anthem, with UHC, Cigna, Aetna, a lot of the regional blues. We're working on trying to get Blue Cross Blue Shield Texas to sign as soon as possible, hopefully in the next few months. And so basically, RAND is helping to facilitate all those data use agreements. And then they take care of securely transmitting that data to RAND. Next slide, please. Of course, we take the security very seriously. We have all the data protection protocols you would expect. It's an IRB approved study. This is an important point. All the participants are kept confidential. We don't put in our report which we actually don't even list which carriers or which health insurance companies have cooperated or participated. We don't put any of that in the report. We just focus on the hospitals and their prices. And we've had a track record across 5 rounds of this study with no data breaches. Next slide. What do participants get out of this? The first thing you get is free public access to each hospital and each health system, what their prices are. So the type of charts that you saw earlier, specifying the price level in your state, the price level of each health system, each hospital. It even goes deeper into the price levels inpatient or just the professional price levels. All the subcategories of prices are published for free. So you would be part of that, not only for your own benefit, but for the public benefit. The second thing you could receive is optional, it's not required. But some employers do exercise the option of asking RAND to break out their claims data only. And so that takes place next year for any employer that participated. And it takes a while to get all that data analyzed, but those are delivered late in 2027 to the employers who decide to exercise that option. But you don't have to decide that when you're joining the study. Joining is free. It's just later you could exercise the option to pay for a private report like that. It costs just $1,000 for small employers or a maximum of $15,000 for the largest employers. So this can help support your awareness of which hospitals are more expensive, your benefit design, your network decisions. This can even help support that without a private report. If you just look at the free public report, you can see which hospitals are more expensive. Also, for policymakers, it helps them a lot because they can see the big picture. They can see whether they need to take extreme measures like some states are doing, California looking at price caps. And they can calculate what would happen, how many hospitals are above a certain price cap, and what kind of benefit that would bring to the state. Next slide. And here's the timeline. So right now we're in the thick of wrapping up our data use agreements. We're hoping that all DUAs and recruitment would be decided by the end of next month. That's just decisions, who is in, who is out. That leaves enough time, a few months, to actually get the data securely transferred to RAND. We're hoping to get all the data transferred by the 20th of November. So the 20th of November is the true deadline for getting your data in. And in order to reach that deadline, you basically have to decide now, May and June. Then by December, we're looking at the data, we're cleaning it, we're analyzing it. That process takes us all the way into next year. And the report is published in September 2027. And then for those ones who order a private report, that comes right after the public report next year. Next slide. All right, so the short answer of how to participate is to email me. No matter what your situation, maybe you are with UHC and you know that we already have a DUA with them, email me. I'll explain to you who at UHC you'd need to CC on your email to get it to happen. For UHC Anthem, it's just a simple email. For others, like maybe your data warehouse or something, it might require a different procedure. But if you just email me, say, let's do it, I could tell you the procedure for your situation. Again, we're trying to wrap up these commitments by the end of June so that the data can arrive by November 20th. Yeah, that's about it. Chris, over to you.
So I think there you have it. I have been really impressed with what RAND has done. We will send an email out to everyone that's registered here with this deck. You'll have that opportunity to contact Brian. We'll put a link to the Texas Employers for Affordable Healthcare dashboard. You can see what's out there right now. And I think doing so will encourage you to want to participate. Again, all healthcare is local, so the coalition in Houston may develop a strategy on how to proceed with this data, different than perhaps Dallas, Fort Worth, different than San Antonio. But suffice to say that the more employers that we have on board, the better will be our collective voice. Maybe to that end, Brian, if you can comment on some of the pushbacks that we have received from hospitals as to the validity of data and why those perhaps aren't sound objections. I don't mean to put you on the spot there.
No, that's fine. Yeah, I mean, the only criticism we've received from the American Hospital Association is that the sample of claims data we're using is never 100%. It really varies by state. If we get the Texas All-Payer Claims Database, plus we get some other employers joining in that are self-insured, we might have a sample that's up to 70% of every claim in Texas. And they would complain that, well, the 30% could be systematically different than the 70% you're analyzing. So how could you draw conclusions? Of course, the answer to that is if I took 70% or even 10% of the receipts of people coming out of Costco or some sort of supermarket, and I analyzed the prices they paid, believe me, I could tell you how expensive Costco is compared to the other warehouse store. You do not need 100% sample to get at what price level you're dealing with. That said, I mean, ideally your sample would not be missing an entire payer because if you truly can't access any Blue Cross Blue Shield Texas claims and you base all your prices on Cigna and UHC claims, maybe it is tough. It's not a perfect sample in those scenarios. So we all have to do our best to get a real great sample of claims data to make sure we shut down any criticisms.
And I was going to say also that's what's been relatively unique about the structure that Brian and the team have built over the years, right? The ability to focus on the self-insured employers that are not present in APCDs sort of is the kernel that started all of this, plus the growing APCDs over the years gives us one of the, both in terms of breadth nationally and depth in states, No, it's never going to be absolutely 100% of claims, but it is a heck of a lot broader and deeper than most other analyses of healthcare prices too.
Well, with that, I think we're going to give everyone a few minutes back of their 30 minutes here. Again, we'll send the recording, we'll send the deck, and a note of encouragement to participate. This is truly a unique opportunity that has benefited employers that have participated in the past. So we hope it will benefit you in the future. So with that, thank you. I hope you all have a wonderful weekend and best wishes.